Hold on.
Good afternoon, everyone, and welcome. We will be starting the webinar in about 2 minutes. Just want to give a little time for everyone to sign on. Hello and welcome, everyone. I'm Tom McDermott, Regional Resource Director for Central PA at Karen. Thank you for joining us for today's webinar on the topic, Family Relapse When Patterns Reemerge. As a reminder, we will be conducting this session in webinar format, meaning all participant microphones will be muted. We will not be able to see or hear you. During the presentation, please utilize the question and answer or chat features to ask any questions. Depending upon the volume of questions, if we can't get to your question before the end of the hour, we will have someone from our team follow up with you directly. Today's presentation is eligible for one continuing education credit. We would like to thank our educational partner, CE Learning Systems, for assisting in providing these credits through co-sponsorship with the American Psychological Association. You must be on for the duration of the webinar in order to be eligible for your credit. Please note that in order to receive your credits, you will need to complete the post-webinar evaluation. A link will be emailed to you directly after the presentation from cego.com. After finishing the evaluation, you will have immediate access to your certificate of completion. Today I am proud and excited to introduce our presenter, Erin Goodhart. Erin is the Senior Clinical Director of Women's Services at Karen and has worked at Karen for over 17 years. She has clinical and administrative oversight of Karen's Teen Female Program, Young Adult Women's Program, Adult Women's Program, Relapse Women's Unit, and Family Services. Additionally, Erin is an adjunct professor at Alvernia University in the Behavioral Health Department. Erin is a licensed professional counselor. She is also certified as an advanced alcohol and drug counselor, advanced certified relapse prevention specialist, clinical supervisor, advanced certified relapse prevention specialist, and a certified sex addiction therapist. She's trained in cognitive processing therapy and has earned provider status. In addition to her clinical work, Erin writes blogs for Karen, including her most recent post, Coping with Post-Vaccine Holiday Stress. Erin is passionate about helping families to overcome the stigma, shame, and barriers that keep them from seeking treatment and engaging in an active recovery program. At this time, I would like to welcome Erin.
Thanks, Tom, and thank you everybody for joining us here today. So my name is Erin, as Tom said, and we're going to spend the next 50 or so minutes talking about the relapse process. So several months ago, I did a webinar on relapse process as it relates to women specifically. And one of the things that I've always been sort of curious about, and one of the things that we've begun to address in our family education program, is what the relapse process looks like for family members. A lot of our focus is on our patients, the identified person, and things like that. So I'm hoping that we can spend some time looking at what the relapse process for family looks like, and how we really help them to intervene on that process. So as we get started, one of the things that we see often with families is that, there's a difference between families who have their loved one in treatment for the first time. So this is the person who's coming into outpatient or residential care for the first time, trying to get sober, and the families are also having their first introduction to sobriety, to recovery, to therapy. And there tends to be this sense of hope, that things are going to change, that things are going to be different. And for some families, it's also kind of scary because they're recognizing that it's not just about their loved one getting well, but that the family system actually needs to change. And so, I've worked with a lot of families of both, patients in treatment for their first time and relapse families who are a little surprised that they're actually going to have to change some of their own patterns, some of their own behaviors and their own interactions. On the other side of that, here at Caron, we have a relapse program for patients who have been in previous treatments or may have had periods of sobriety and relapsed. And oftentimes those families are the tougher families to engage in the treatment process because they've been through it. They've heard, I'm not going to do it again. They've heard all the education. They've had family sessions. So they're really full of fear and often anger. I think some of the more difficult families we've worked with are the families of our relapse patients. And because really, for our relapse families, they're along for the ride with their loved one. One of the things that we also know is that family discord, family troubles is really likely after treatment. And that could be for a multitude of reasons. That could be because, perhaps we're asking families to change their own patterns of substance use. The families are realizing that, they're not going to be their loved one's primary support. And we're going to talk about that as we look at the relapse process for family members. The other thing that we really know is that humans by nature have a need for attachment and for meaningful connection. I know when I was sort of preparing for this, and as I talked with family members, had done some research, attachment is one of the things that helps us survive. We know that people who have meaningful connection and meaningful attachment, they're happier, they're more resilient, they're more successful, and they tend to live longer. We are by nature meant to be with other people and be supportive. And the thing that is interesting with substance use is, often when we have other people in our lives or when we're giving support to other people or even therapy, if it's a medical diagnosis, we tend to say, go towards that person, attach more, connect with them more, support them more. But the funny thing with substance use is it's like, people often say you have to use tough love or, you need to set boundaries, you need to stop enabling. But the truth is that desire for connection is there even with a chronic disease, right? And so that's been like a real shift that we've really started to make when we look at working with our families. Because a lot of our families will say to us, what boundaries should I put in place? Should I tell them that they can't come home? Or, and the reality is that it's up to every individual family member what boundaries seem realistic for them. But when we think about it, there are some also kind of general reactions of family members, either, when their loved one comes out of treatment, when they've finished with either an IOP, an outpatient program, a residential program, whatever it looks like, the reaction of families is sometimes takes longer to change, actually. So what we see family members who might respond as if their loved one were still in active addiction. So we're going to see all these things that we saw previously, right? We're going to see things like, the patient is saying, I'm going to my meeting. And the family member really wants to believe that, but there's this voice in the back of their head that is saying, well, maybe I need to follow them. Maybe I need to ask them how, if they talk to their sponsor and what that looked like. Did they go to the therapy session? So all of these old behaviors that family members had as a way to try to protect their loved one from their active addiction continue on. In our family education program, this is something that we talk a lot about with family members, is that these responses that families have are normal reactions to an abnormal situation. So again, like, I think as professionals, if we can start to sort of widen our view on things of, these aren't necessarily bad behaviors, or they're not codependent behaviors, but these are things that when you have a healthy attachment to somebody, when you love and you care and you have a meaningful connection with them, these are like normal reactions. And being able to look at, how do I manage them in a moment, right? So I'm not following my loved one to their AA meeting. I'm having a conversation with them before they leave treatment or while they're in a therapy session of, how can I express concern to you when I see it? When I do a family session with my patients, I always am asking family members, how much do you want to know about their desire to use or drink? Because it's normal in early recovery. And I really try to emphasize that. So we do an exercise, how much do you want to know? Do you want to know if they're having cravings? Do you want to know if they drove by the liquor store or they went to their doctor's office? And when they say yes, then I'll ask the patient, what response do you want from your family member? Because trust me, they're going to want to control, they're going to get worried, they're going to move into caretaking mode, they might even get confrontational with you. So when patients or clients are in an office or in a therapy session or in a residential treatment, I would rather have this conversation, when they're in a healthier spot and they can actually have some dialogue around it. One of the questions that we had gotten, prior to this is, what does enabling mean? And you'll see that on the list here. And so the simplest way that I have found to describe enabling is, it's doing for something for someone else when they can do it for themselves. So these can be really simple things like, one of the things that we'll talk a lot about is, if I have a family member who, wants to have a difficult conversation, maybe with their patient or with their patient's therapist, allowing for the patient to be a part of that instead of doing something that they could do for themselves. Enabling can be as big as, I'm going to make excuses to your employer about why you're not there. I had a really interesting experience where we had a patient come into treatment and their child was put in a position to lie to their family, to protect their parent who was in treatment. And so when we started, when she attended the family program and she saw this slide, she was like, oh my goodness, I'm enabling this, secret to continue. And so we had a really healthy conversation of, to the patient, the daughter being able to say to her mother, it's really difficult for me to continue to lie. Like, it doesn't fit my value system. And they had a healthy dialogue. And ultimately the patient was like, well, go ahead and tell them if that's what you feel like you need to do. I'm comfortable with it. But the patient was a part of that conversation. Enabling is natural. It's normal. Like I said, all of these behaviors are a normal response to an abnormal situation. Enabling is also something that we do as family members to get relief from a really difficult situation. It is often done out of love, and it's done out of a place to, in the family's mind, they're helping their loved one. So, we've tried to sort of take some of the pathology out of enabling behaviors and really have started to look at it sort of through this lens of, this is something you're doing out of love and out of a desire for connection and a desire to, have a meaningful relationship. And that has helped families to kind of step back a little bit. Even our relapse families who have been through this time and time again, they'll call us in our first conversation. They'll be like, I should have made them come back sooner. I should have, taken the kids and left. I should have held my boundaries. And all of those things are true. And the truth is, they did not hold their boundaries because it came from a place of love and care and concern. So I know that's like a bit of a shift, I think, sort of from where we have been in terms of looking at family relationships and enabling and codependency and all those things. But I think it's like an important place for us to kind of start looking at this as professionals, is how do we also destigmatize the response that family members have to having someone in active addiction. So, I think starting that process. So what I want to pull up here is a family relapse cycle. I know this is a super busy slide, but for most of you, this probably looks familiar. This is really loosely based off of, or closely based off of, Terence Gorski's relapse cycle that we see for patients, for people in recovery. And the reason I like to use this with families is it gives a common language from which to speak. I think as much with our families as we can give them common language to speak with their loved one, we allow for the recovery process to happen, and we allow for it to be inclusive. So, what you'll find as you're looking at this is, there's a real desire from family members to kind of be on this journey with their loved one. At least initially when there's that crisis, right? And we see out with our patients all the time, the crisis occurs, they commit to stabilize, they go through this process, and some people ultimately end up relapsing. But if we take Gorski's relapse process and a relapse cycle and sort of relate it to family members, we can start to see some same patterns of behavior. So I'm going to take just a couple of minutes and kind of go through this as we look at it through the lens of a family member. So there's this commitment to stabilization. Okay. So families, I say to most of our patients, most of you haven't come in, like woke up in the morning and was like, I'm going to go to rehab. I'm going to go to outpatient. I'm going to go to therapy. I'm going to go to AA. There's usually an external motivator, right, to get them to come into treatment. And they have this commitment of like, okay, I'm going to give this a try. And when family members bring their loved one into treatment, some of them are like, all right, well, let's just drop them off and let's hope this works out. For our chronic relapse patients, they understand that this also takes a commitment on the family member side. Or perhaps they don't, and that's part of what has kind of kept their loved ones sick as well. So one of the things that we need to be talking about with our chronic relapse patients' families is, are you committed to this process also? And what does that look like for you? One of the things that, when we talk about families is they always want to talk about their patient, their loved one, their daughter, their mother, their partner. And what we try to do is put the focus back on the family member of, okay, so, how are you going to take care of yourself, whether or not your loved one stays well? What is your commitment to stabilization? Does that look like, I can't talk to them for a week? Does that look like, I need to have my own therapy? Does that look like, they forgot their personal items? I'm not going to drop them off right away, right? So what does that look like? What does that early boundary setting look like? Along with a commitment to stabilization, there's also a utilization of a recovery program. Now, anybody who's familiar with Terence Gorski is going to say, I utilize a 12-step recovery program. I think also, especially with our relapse families, being open to what does a recovery program look like for them? Does that mean a church group? Does that mean a yoga group? Does that mean, there's a lot of movement with groups of people that exercise together also in terms of having that be a recovery group. I think about some of the folks who ride bike or run or lift or do yoga together, right? What does the recovery program look like? And along with that, who are the family's support people? Because a lot of times chronic relapse patients are embarrassed. They're filled with shame. They don't want people to know that they've relapsed. And so that kind of paralyzes the family members also, because they're sort of in this position of like, well, they told me not to tell anybody they went back into treatment, or, and so it's like working with the families to figure out, okay, so how do you continue to have a support system for yourself? And how do you utilize that program of recovery? For family members, again, either of primary patients, people have never been in treatment before, chronic relapsers, this I am cured. And it's not as if they, say, I don't need therapy, or I don't need to get well, or this isn't a problem anymore. But it is like, maybe I don't need to continue to go to therapy. Maybe I can start to, spend time with people who might be against my loved one, or I don't need to continue with my recovery program. It's much like our patients, right? So like we will say to them, they never say like, boy, I don't have the disease of addiction anymore, but they will start to kind of play games and like barter and make agreements with themselves. I stopped growing. I think that is a result of stopping with support, stopping therapy, stopping self-care. One of the things when we think about utilizing a recovery program is we're also looking at self-care. What does healthy eating, healthy exercise, healthy support look like? In that I am cured and the I stopped growing phase, those things start to take a back seat. The other thing that is really interesting with family members as we look at sort of their return to old behaviors and attitudes and beliefs is, when the crisis is happening, there's this like anything that you need to do, right? Like you need to go to IOP 3 nights a week. I'll get the, dinner made. I'll get the kids to soccer practice, whatever you need to do, you just take care of yourself. And what we see happening over time is families get frustrated too, right? Like, okay, so how long does this go on for? Like you have been sober for 90 days. Do you still need to do your meetings every day because you did your 90 and 90, or you've completed your IOP? So there's this return to old thinking that can happen for families. And that can look like a bunch of different things, right? That can look like, my loved one is selfish, self-centered. That can look like, oh, here they go. They get to take all the time that they need again to be healthy. Old thinking can also look like, I'm taking a back seat to them. I was recently working with a family, and we were talking a lot about the recovery process for this person and what they needed to do in order to maintain their recovery, with building a support system, with going to IOP, with going to AA. And their partner said, where do I fall in this? And it was a really impactful question, because that is something that comes up for family members of like, wait a minute, where do I fall in this? Where do I take priority? Because when you're in that crisis stage, the family is, again, like whatever you need to do to take care of yourself. But as recovery happens, it's like, wait a minute, the kind of the flag comes up and it's like, where do I fall in this? So that can be some return of old thinking. Return of old thinking can also be that return to suspicion, that investigation that happens, that, boy, they were out for 15 minutes longer than they thought they were going to be. Maybe they're up to old behaviors, things like that. Return to old thinking could also be things like maybe it wasn't that bad, or maybe, at New Year's Eve, we can have a glass of champagne, right? So like these old thinking patterns start to return. Then we see stress. And again, this can be related to either the families taking a lot on and like thinking that they'll be able to give something back to their patient, their loved one. This can also be, ideally the person in recovery from the substance use disorder is building their own support system. And if the family members aren't also building their own support system, it can become stressful for them, because they, sometimes don't want to go to their loved one because they're like, well, they can't handle it yet, or I don't want to make them relapse, which is like one of my favorite things that I hear family members say. That's return to old thinking, right? Like, I'm going to make them relapse. And so we talk a lot about, the recovery process is squarely in your loved one's lap. There's things you can do to contribute, but you're not powerful enough to make them use or not use. Families have tried that for so long, right? So this stress tends to come in, and it all builds on each other, right? So I've stopped doing my self-care items. I've stopped going to the gym, eating healthy, having balance, prayer, meditation, support. And then I start returning to these like thought patterns of, when do I get time in this? Or I can't ask them to do anything additional because I don't want to make them use or make them return to unhealthy behaviors. And so then I start to have stress and problems. And then what happens is I return to old behavior. And for family members, old behavior can run the gamut, right? It can be things like being overly controlling. It can be things like, well, I'm just going to throw my hands up and do nothing. It can be things like, for some family members, it's overeating. It's overly engaging in work. It can be micromanaging things. But the return to old behaviors is really about the things that families did when their loved one was in active addiction to attempt to control the situation. And so helping them to start to look at, not only for your loved one, what are their return to old thinking patterns and old behaviors that are red flags, but for family also, what is the red flags of old thinking and old patterns of behavior? That can be avoidance, which leads into isolation, So if I am avoiding my loved one who's in recovery, and I don't have an established support system, and now I'm avoiding, difficult conversations, or I'm avoiding social events, or I don't like to go to the AA Thanksgiving dinner or gratitude breakfast, right? I start to have isolation and avoidance. And then what starts to happen is I begin to feel overwhelmed because I don't have a support system, and I feel like I'm in it alone as a family member. Or for our chronics relapse patients, they're like constantly waiting for the other shoe to fall, right? So I may have been down this road with my loved one where they've gotten 9 months, a year, 18 months. But in the back of my head, I'm so fearful that there's going to be a return to substance use that I'm overwhelmed and anxious. And then I don't know about you all, but I know when I get overwhelmed and anxious in general life, I have this intense need for control, where perhaps I feel like I can somehow influence other people. I lose my mindfulness practice. The focus becomes about other people and what other people are doing or not doing. The next step in this is I become resentful, filled with shame and blame. I can start to become resentful of my loved one, be resentful of their support system, be resentful of my lack of support system, of the things that, I need to do in order to be a supportive recovering person, or be supportive to a recovering person. This also tends to be sort of like where reality sets in, that life is going to be very different. I think one of the things that is important in preparing family members is that life is going to be different. And it's funny, I think our patients who come through treatment for the first time, they'll say things like, I can't go to that restaurant I used to drink at, or I don't want alcohol at home, but my partner can drink outside of the home. And I like to use the analogy with them, if you were getting chemotherapy for lung cancer, would you be okay with your partner smoking next to you? Would you be okay with them coming home smelling like cigarettes? Most people would say no. But what can happen for family members is they kind of get this resentment of like, wait a minute, you're the one in recovery, and I can't go out with my buddies to a football game and have beer, or I can't go out to a nice dinner and have a glass of wine. So it's this resentment that can set in. And then, you can have a return to obsessive destructive behaviors, right? This is like the actualization of the relapse, if you look at it from a patient's perspective or from someone in recovery's perspective. So this can be that confronting. This can be, there's this parallel when you think about substance use and return to substance use, where the patient, they get obsessed with using. How are they going to get more? When are they going to get more? Can they get more? What's going to happen if they can't? And what happens for family members is they have this like parallel process that occurs where they're obsessed. Are they going to get more? How are they going to get more? When are they going to get more? Am I going to be able to catch them if they get more? So this obsession occurs for both the person in recovery from substance use disorders and their families. We also see this return to destructive behavior. So even if the identified person isn't using, they might return to anger. They might return to overworking, sex, gambling. And family members might resort to the same thing, those same destructive behaviors of using work to avoid, of using sex, gambling, maybe their own substance use disorders. So the reason I like to, kind of propose this to families and patients is because we can see a similar process that occurs. And I'm not saying that it occurs at the same rate, right? So we can have a family member who's in full-blown relapse process and a patient who's still in their utilization of a recovery program. Because oftentimes our families have done in their mind, they have, done everything they can to try to keep their loved one from using, from self-destructing, from returning to old behaviors, that it can be really uncomfortable for the family member to have to take the step back and kind of do their own work, if you will. And that's really one of the things that, when I was looking through some of the questions that we had gotten about for this webinar was, how does the family help the loved one? Their person in early recovery or the person who might be in the relapse process. And the truth is that the best way that family members can help their loved one is by helping themselves. And that is very counterintuitive to what family members have known historically, and also kind of what that gut initial response is. When we have someone in our life struggling, our response is to try to help them. And in substance use recovery and behavioral health recovery, helping them might look like taking a step back. It might look like having your own support system as the family member. It looks like allowing your loved one to have some consequences. I say to our patients all the time, as long as you have one person who's going to remove your consequences, you really don't have to stop using, right? One person who's going to bail you out of jail, one person who's going to make excuses for work, one person who's going to give you money. You've not really felt the full capacity of your consequences. So with the families, having them taking this step back and really focusing on themselves, that is tough for family members to do, and it's scary. So I give you this kind of cycle as a resource to use, to start to compare, especially for our folks who have family members, loved ones who are chronic relapsers, really helping them to kind of look at this, the family member, what does their relapse process look like? And how that return to comfortable, familiar, yet unhelpful behaviors kind of keeps us stuck in this pattern. So really, what can we do? How can we help family members to understand how to kind of get out of this process or how to intervene on this? Because the reality is family members are going to go through this. They're going to go through this process. And just like with the identified person, finding an intervention point is what is most important. I will say to people all the time, even people in long-term recovery have relapse behaviors every day. And it's really about what they do when they realize they're in this cycle. So for the family member, when they realize, oh my gosh, I am obsessing about where my loved one is because they should have been home from their therapy session 10 minutes ago, I'm in this process. And so when I'm in this process, what am I doing to take care of myself? So that I'm not putting my anxiety and my fear and my anger on my loved one, but I'm really starting to develop some emotional sobriety as a family member also. So some of what I'm going to review is some of what we talk about in our family program also. And I know that some of the things that y'all had asked for was like, what are some tools that we can give family members? Because, I'm also a big fan of looking at what is the solution for things, not identifying what the problem is, being aware of what the problem is, and then how do we move into solution? So I'm going to talk about 4 different sort of topics here. Understanding the 3 C's, which we're going to get into. Assessing your contribution, which is really the 4th C. learning and practicing AID rules, and then developing healthy boundaries. Now, I will tell you that families always want to focus on the healthy boundaries piece. They want to look at what boundaries they're going to put in place in order to keep their loved one well. And what I encourage is to sort of flip the script. What boundaries are you going to put in place to keep you well? So again, it's not focused on the outcome of of the loved one, of the person who might be in a relapse process or might be in active addiction or early recovery. The boundary isn't focused on their success. The boundary is focused on protecting yourself. And I think that that's a real sort of way to differentiate between self-care and trying to fix somebody else. So if we look at the 3 C's, I didn't cause it, I can't control this, and I can't cure it. So cause, control, cure. Most of our, I shouldn't say most, there are some of our relapse patients' families who, you know, when we're talking with them, they go either way, right? Some of them are like, I had no idea this happened. I had no idea how we got here. You know, I'm totally shocked. And there are other families who will say things like, well, I was drinking around them. You know, sometimes they're like, the families are the ones who say, I said, you can just have one, right? They're part of this relapse process. And we look about contributions, that's what we're talking about. But the reality is, there's nothing that family members can do to cause it, control, or cure it. And for our family members, that's often very freeing for them, because families carry around just as much shame and guilt, sometimes even more so than the identified person does. So really helping them to look at, you know, are there things that you've done to contribute to the crisis? And where have you not caused it or controlled it? So we start to help them kind of pull these things apart a little bit. And it's important to remember in this is this isn't about blame, right? This isn't about it being their fault or them somehow, the family member somehow taking on the patient's responsibility of recovery. But there can be things that families do to contribute to the building up of a crisis. You know, I think, again, when I go back to some of the families we've worked with, is looking at how do you have conversations about family members' fears? What are their red flags? So, you know, I'd worked with a family recently, and one of their red flags is when their loved one went into the guest room. They could have been going to the guest room to fold laundry. They could be going to the guest room to do yoga. But one of the things that happened for their partner is when they went into the guest room, anxiety set in, anger set in, fear set in, the family's need for control set in. And the patient was able to say, you know, when that happens, it makes me feel like a caged animal. So we were able to look at how does that person's partner say, it's really scary for me when you go in the guest room, and the patient able to say, I hear what you're saying, and these are the commitments I'm going to make in order to help you feel safer, at least initially, right? So things like, I'll leave the door open. I will announce when I'm going in there, you know, so that the family member's own fear and anxiety didn't contribute to this crisis building. If we look at the AID rules, so we talk about allow, inspire, demonstrate, and then refer, unite, love, embrace, and self-care. So these are some of the things that when we are working with family members to help them sort of focus on themselves and to help them intervene on their own relapse process, it's just a nice sort of acronym to be able to keep that in mind. So the first one is allow. This is allowing for consequences and learning. You know, when we started this off, you know, had the one slide there about what enabling looks like, and you know, really looking at doing for somebody what they could do for themselves. And I would say the same is true for consequences. Working with family members to help them understand that sometimes their loved one needs to have consequences in order to grow, in order to make changes and ultimately learn. And there are going to be times, even for our family members, where they're going to have consequences, where, they might set a boundary and their loved one might not like it and they might not talk to them, right? But again, a boundary is not for the other person, it's protect oneself. So with this we're allowing for our loved one, the identified person, to have consequences and to learn from that. We're working with the family members to stop protecting, shielding, bailing out, and lying. These are common behaviors or old patterns of behavior. We go back to that relapse cycle, right? Return to old patterns of behavior that we see family members engage in over and over and over again. And we even see this when they're in treatment, right? We'll see, that they're protecting their loved one. Like, here at Karen, we have rules around phone, right? And so there will be times we'll get to the end of a treatment and the family will say, oh, just, they talk to me every night for 30 minutes. And it's like, all right, so let's stop for a second. Let's have a conversation about what happened for you in that moment that you allowed that to continue, instead of saying like, hey, just so you know, they're on the phone for 30 minutes, or saying to the patient, you're only supposed to be on the phone 15 minutes. I'm going to end the phone call, right? That would be a real recovery based response from a family member. And then also this, by allowing, it also allows for the identified person to build some integrity, to build some perseverance, to practice these skills that maybe they haven't used for a really long time, with having difficult conversations, with being honest about what they're feeling emotionally, with, having some consequence, right, for their behaviors and their interactions. We talk about demonstrating a lot with our families. We encourage families to go to meetings or support, have their own therapist. There's a lot of, and it's, again, a lot of our relapse families, they're either in their own therapy, have their own support groups, or they're just so frustrated. But really encouraging families that they need to have their own support group, where they can feel comfortable and safe to talk about whatever crazy making is happening in their mind. Sometimes families are really uncomfortable with the identified person getting well. Because one of the things that we talk about a lot with family members is, if my partner is always the identified person and my energy is always focused on that person, when they get well, what is my purpose now? What do I do? Where do I put my energy? For sometimes like, okay, then I'd focus on myself. So I need to have my own support system. I need to have my own therapist. I need to have people that can also hold me accountable. We talking about feelings. I think some of the most impactful family interactions I've had is when it's been very difficult, when it's been the family member saying, like, I really feel scared about this. Or, every time you've called me from treatment, it's been like a laundry list of things you need for me to do. I'd really like to have a meaningful conversation with you. Again, having family members identify, like, what are your triggers? What are your red flags? And having a conversation with their loved one about that. And then also, finally, with demonstration, developing and using healthy coping skills, whether that's having appropriate self-care. And I've done a lot around self-care in terms of, reading and writing and presentations. And, self-care can be as simple as, I'm going to take 5 minutes and go outside and do some deep breathing. Self-care can be, I'm going to, make this fruit tray or whatever that I really enjoy. It doesn't have to be like a whole day at the spa, but it can be little incremental things throughout the day that one does to have appropriate self-care. But really what we're asking the families to do is demonstrate that commitment to stabilization, that commitment to utilizing a recovery program, and really staying invested and not allowing the identified person's response to recovery or their relapse behaviors to, greatly impact. But we're still demonstrating as the family member that I'm in this for health. We look at inspiring. So we're sending the message we're asking family members to send the message to their identified person that they're capable, that, you know, having compassion and, you know, I have on here being positive, and I don't mean like Pollyanna positive, but like, I believe that you can do this. I know that this is going to be very difficult, and it's very difficult for me, and I can hear your pain, and I can share in that. And, you know, I will work on not overreacting when you tell me that you're struggling. Because the reality is our family members, when they hear that their identified person is struggling, it's scary for them. And some of the, you know, most powerful interactions are being able for the family member to say to their loved one, like, I'm really scared when I hear that. Don't have to fix it. Don't have to solve it. I can just own my own feeling, right? But we can be compassionate, and we can have empathy as family members, and still know that ultimately the ball is in the identified person's court, but we can still be in their cheerleading squad. I also think from a therapy perspective, this is something that has recently come up quite a bit in, you know, at least in our supervisions on the women's team, is really looking at, you know, how does this installation of hope occur? Because we've all worked with patients where we've recommended, you know, whatever, and they've chosen not to do that. And how do we still inspire them and kind of have them leave with this sense of hope that they're capable, and you know, that we're here when they struggle, and that we can continue to have compassion and empathy. So for me, this like inspiration, this installation of hope piece is really important when we're working with family members. And ultimately, you know, I think as professionals too, and working with family members, that we're also sort of inspiring families also to say, look, we believe that you're capable. We know that this is difficult for you. And even if your loved one isn't able to stay well, you can still have a meaningful experience. So for me, the inspire is both for us as professionals and working with family members, but then the family member to the patient. So it's really this kind of parallel process that occurs. We can start to untie. We encourage families to focus on their own emotional well-being, gain independence, and focus on their own values and beliefs. You know, and really looking at, again, how can I continue to grow emotionally, spiritually, in terms of relationships, even if my loved one is struggling, right? How can I start to develop some differentiation there, or some boundary there, right? That I can still be fully present with you, and I can still continue to grow. Love, you know, this is something that, you know, tough love until they love themselves. Like, it can go a whole different directions, right? But ultimately what we're talking about with our family members is loving without trying to fix them. Being present with them, being able to sit with them in their pain, and know that, you know, we can't love people well, right? But we can still have compassion and empathy and care for them. Also, in terms of this with family members, we're also encouraging them to ask for what they need. Being able to ask from their loved one what they need, being able to ask other people in their support system what they need. Then finally, you know, my big push with our family members is always around self-care. What can a family member do to take care of themselves, either while their loved one is in residential treatment, whether they're in outpatient treatment, just, you know, going to support programs, practicing something every day to have self-care. You know, we talk a lot about putting your own oxygen mask on first. Our family members get so focused on helping their loved one that they forget that if they're not taking care of themselves, they're not going to be available to their loved one. I'm a huge fan of starting small. Again, it might be a 5-minute, I'm going to go out and take some deep breaths out on the, you know, patio. It could be, I'm going to take, you know, 30 minutes and go for a walk, right? Self-care doesn't have to be these huge, long things. It can be reading a book you enjoy. And really, some people confuse self-care with selfishness. And so, it is the greatest act of love you can give yourself, to be able to really focus on yourself and to be able to give yourself some compassion. And also part of self-care is practicing healthy boundaries. Um, you know, I'm sure, we've all been asked a million times, what boundaries can I put in place? And I always flip that back to the family. What's reasonable for you? Because I could give you 15 recommendations, but if they're not things that you're willing to do, all it does is reinforce this pattern that I'm going to set a boundary, you're not going to follow it, and I'm going to bail you out. So we really start to look at what self-care looks like for our loved ones and how we can encourage that as professionals as well. Tom, are there any questions from your end?
There are some questions. Erin, thank you so much. Really appreciate it. So the first question I'm going to answer, and that is that we will be sending a follow-up email in about a week that will have a copy of the PowerPoint as well as access to the recording. So the first question, Erin, is kind of two parts. So can you discuss the best things that we can do to support friends that have an active addiction? And the second part, I'm going to kind of put them together, is can you also talk about kids and teens who are dealing with parents who use and may never have completed treatment?
Yeah, those are great questions. So, there are actually quite a few resources available for teens and kids who have parents who are in active addiction or may have just completed treatment. So of course, there's things like Alateen. Karen has a children's program that is accessible, that's virtual right now. The other thing that I really, encourage, especially children and maybe other folks who might be aware of children who are in situations like this, is I really think school guidance counselors can really be a resource for kids that are underutilized in terms of getting support for them. Obviously, if there's any concerns about safety, that's a whole different issue. But really, I think both for kids and or teens, young adults, and also for if you have a friend who might be struggling, I'm a big fan of like open up the conversation, right? Of saying like, these are things that I've seen and I'm concerned, or inviting them to have some sober activities. So instead of going out for happy hour, maybe you're going out for yoga and breakfast, or, instead of going to, again, out for dinner, maybe you're going for a walk, or, just helping them to engage in some activities that generally haven't revolved around alcohol. And I'm a huge proponent of just opening the conversation. I really feel like if we can open a dialogue, it reduces the shame, it reduces the stigma, and lets people know that you're available should they need support.
Thanks, Erin. Next question. So, how does a family proceed when some family members are not interested, engaged in the recovery program, and others are?
Well, my initial response is that depending on where the identified person is in the recovery process, they're going to gravitate either towards the people who are motivated to be in recovery or not. I also think that education is helpful, but to some degree, the pain has to be great enough for the family that they're willing to make changes. So I know as a therapist, I find myself in positions where I'm like pleading with patients or families, and I have to like take a step back and realize that I'm not even dealing with somebody who's in active recovery. They may not be in active addiction, but they're also not in active recovery. So I think part of this is understanding as a professional, our own countertransference, having really good supervision, and then also being able to know in the family system, who are the people that we can pull on, who are the maybe, the loudest voice in the family, or, the one who's sort of got the most pull, and being able to tap into those folks. But I also think, sometimes we're 3 steps ahead of where the family is. So sometimes it's about taking a step back and really providing some good assessment, some quality education, really pulling on those motivational interviewing skills, of is the way that you're living where you want to be? How do we move folks along, meet them where they are? Because I have found with families, some of the biggest barriers that I've faced is I'm 3 steps ahead of where the family is. The only thing I'd add about that is, if possible, having family meetings or even smaller family meetings where there's open communication, because I think sometimes people can get triangulated in systems like that, where there are some people who are motivated for recovery and some not. That if we can all kind of have an open dialogue about what the fears are about the family being in recovery, or about kind of what some of the hesitations and hopes are, it opens the door for a more transparent conversation.
I think we have time for one more. I'm going to sneak one more in. So, if a child is in active addiction and using in the home, is it advised to request they leave the home if they are unwilling to go to treatment, as harsh as that sounds? That's like the $1 million question, right?
I was gonna say that's like the magic question there, Tom. Before I answer, I'm going to go back to something else. I think that there's a lot of resources for children who have parents that are using. I think an area of improvement for us is when we have opposite way around. We have a lot of resources for kids who are using for parents in order to get support, but I do think we would benefit from having more support for children who have parents using. This just as a sidebar. I think that's an area of improvement that we have. In terms of, do I ask my kid to leave? I wish I could give a really solid answer about that, but I think what I would default back to is in terms of boundaries, saying, if you don't stop using, I'm going to kick you out. I think for most parents is not an easy boundary to set. It might be easy to set, it's not easy to follow through on. But I do think, starting with what are some boundaries that you can put in place that you can actually follow through with, that might be very small. So, I have a couple of thoughts running through my head, and I know we're crunched on time, so I'm just going to try to say them as best I can. But, I think the first thing is, if they're under 18, you can't just kick them out of your house, right? If they're over 18, you can say things like, one of the things that I value is, it could be something as simple as, in order for you to stay here, you need to be home by 10 o'clock every night. Because I value, some level of consistency, and that helps me with that. And if they choose not to, then you have to decide your consequences. It could be, I'm going to kick you out. It could be, I will take your keys because I pay the car rent or the car bill. It could be, I'll take the insurance. I'll stop paying for your cell phone. Like, I think those are more reasonable things that parents can do, as opposed to, I'm just going to kick you out. My experience has been is families will threaten that, and there's not follow through, and that allows the addiction to continue.
Thanks, Erin. And again, thank you for your very informative presentation, and to all of our attendees for joining us today. As a reminder, this presentation is eligible for 1 continuing education credit. Watch your email for a link from cego.com to complete your evaluation. Before we close today's session, I'd like to remind you to watch your emails for information on our upcoming webinars. As well, yesterday Karen sent out an email containing information for professionals on holiday barriers to treatment and how to support your clients during this stressful time. This included a video on how to minimize pressure and simplify the holidays. Please check it out. In the meantime, please reach out to your local regional resource director at any time for additional information, resources in your area, or questions regarding admissions to any of Karen's programs. Again, thank you for joining us. Have a great afternoon and happy holidays.